is Inesh, and for my research and my presentation, the topic which I'm presenting is establishing thyroid reference ranges for the Indian pediatric population. Thyroid hormone, as we know, are essential for vital physiological functions, including metabolism, bone growth, and development. In children, hypothyroidism can lead to compromised physical and cognitive development. Most developing countries, therefore, have implemented mandatory neonatal screening of TSH and other thyroid function tests to rule out congenital hypothyroidism. Reference intervals from the backbone of the clinical decision making in numerical laboratory reports, and that's why we come to today's challenge that there is a lack of accurate pediatric reference ranges in India. Creating accurate pediatric reference intervals for various laboratory tests necessitates appropriate age and sex-specific divisions owing to the dynamic physiological changes in the hormonal milieu reflective of a particular development phase in the pediatric age group. Biological factors like nutrition and lifestyle may also impact the thyroid function. Current clinical practices relies on reference ranges derived from Western populations which may not be appropriate for the Indian population. So the aims and objectives are to establish age and sex-specific reference intervals for the thyroid function tests, mainly TSH, T3, T4 and anti-TPO in healthy Indian children 0 to 18 years of age in coastal region of Karnataka. So the methodology used was, by the way, this is a prospective observational and cross-sectional study which was conducted over 2 years at the Tertiary Scale Institute, and IC clearance was taken and written and informed consent was obtained from the guardians from each participant. The age groups, the inclusion and exclusion criteria have been mentioned in the slide. 2 ml of fasting blood was drawn in a plain red cap BD container, and the sample was allowed to clot for half an hour, after which it was centrifuged for 10 minutes at 3500 rates per minute to obtain the serum. After which, the DFT values were measured in the serum using the ICHTR technology in the COVAS E601 immunoassay module. EZR software was used to examine the data collected, and statistical analysis was carried out. So the results. The study analyzed 522 participants, which included children and adolescents, up to the age of 18 years. And further exclusion was carried out in the 522 patients using the inclusion and exclusion category, excluding 34 more patients. And this is the final sample size which we used for a study in each age group of the pediatric population. The reference intervals were calculated using the median and the interquartile range for each age group. And as you can see, pay attention on 0 to 3 months and 13 to 18 years. The free T3, T4, TSH and anti-TPO values vary significantly. 2.24 for T3 and 3.3 in the age of 13 to 18 years. Same for free T4, 1.79 in 0 to 3 months, whereas in 13 to 18 years it is 1.32. 1.14 for TSH, 2.42 for TSH, anti-TPO 5.7, but 11.3 for 13 to 18 years, telling us that there is a significant difference in the reference intervals of TFTs in the pediatric age group in India. So hypothyroidism, as we know, is a condition to worry about, and it accounts for around 15% of pediatric disorders. Normal thyroid gland is essential for critical development in people, especially children. Reference intervals, the central 95% of the expected laboratory test results in a healthy, metabolically stable population, and it is critical for interpreting the pediatric laboratory findings. Also, there are some many limitations, and one of them being ethical constraints. As a result, many laboratories rely on outdated or inappropriate reference intervals from adult populations, hospital retrospective data, different methodologies, or other countries, leading to potential inaccuracies. So this study underscores the need for establishing accurate reference intervals for the pediatric age group. And thus, reference intervals must reflect the dynamic changes in the thyroid function across childhood, helping us in accurate diagnosis and improved management of children. Significant differences were noted, as I already mentioned, and further research is required in this field. So, in the end, I conclude that iodine is essential for thyroid function, and maintaining adequate levels is crucial for the Indian population. Early detection and treatment of thyroid disorders in children are key to supporting healthy growth and development. Accurate identification of congenital hypothyroidism enables early intervention to prevent severe intellectual disabilities in children. Further research into the pediatric thyroid health in India is recommended, especially after carrying out several studies. And these are the references from which I carried out my study. Thank you so much.
How are your results differing from the accepted Western norms?
Ma'am, the values which were different, for example, as I mentioned here, for the age group 0 to 3 months, ma'am, as you can see, free T3 is 2.2 for 13 to 18 years, 3.3. So we can get an average that the reference interval for free T3 is 2.24 to 3.3. However, Western data, especially in US and Japan, gave us the values from 0.4 to 4.5. So in India, if we have a suspected congenital suspected subclinical hypothyroidism, ma'am, that would not be detected if we use Japan or American data. That's why this mandated the reference interval establishment for the pediatric population out here.
So maybe a table depicting the differences between the Indian data and the Western data, showing the differences would be effective.
Yes, ma'am.
Has the anti-TPO any significance?
Yes, ma'am. For autothyroid disorders, ma'am, patients are usually asymptomatic in the earlier phase. So we will not know if the person is actually suffering from any disease, although anti-TPO will have a significant effect on free T3, PT4 and TSH. Therefore, anti-TPO measurement is required.
How was the consent taken for getting the blood for the investigations from the children?
Ma'am, consent was taken from the guardians, ma'am. And also, children were called on, they were routine children who were coming for fever, cold and cough in their first visit. Consent was taken in the first visit for the ongoing test. So either they came in the second visit with a fasting sample, or pediatric patients which were discharging from wards, we took their blood samples after the consent.
And what was the budget?
Budget, ma'am, this is something I'm not that aware of because my teacher herself didn't disclose it to me. But we had a separate booth in order to carry this out as fast as possible in our hospital, where people ongoing for this study were sent to that booth, blood samples were collected and TFTs were measured.